welcome back to another week of Superior Health's COVID-19 Nursing Home Leadership Roundtable conversation. It's great to see so many of you back. We're glad you're here. So today's topic, we will be talking about community transmission rates, and I'll just be giving a brief update on that. And then my colleague Elena has joined us, and she will be facilitating the Q&A session for today. So as always, I just want to invite you, as I'm talking and sharing our content for today, to think of any questions you might have, whether it's related to what I'm sharing or totally unrelated and something else in the COVID world that has been on your mind or you're struggling with or just want some additional input and feedback on. The Q&A session really is your opportunity to ask and raise any of those things. So feel free to jot notes, throw them in the chat, and we will circle back to them at the end of my presentation. So I want to just pause before we get started and just open with a quick icebreaker. So Elena, what do you have for us?
Yes, so my question is, because we are getting to the best time of year in all of our states, in my personal opinion, is where is your favorite place to travel in your state? So what's the best kept secret, your favorite place to go? I can kind of go first. My favorite place, I live in Michigan. My favorite place in the state is an island called Beaver Island. So it's pretty close to Mackinac Island, which you've probably heard of, but there are cars there. It takes a little longer to get there, but Beaver Island is my spot. So I want to hear from a couple of you. We'll all be hopefully getting to take some time off and go on vacation, and maybe this will give some people some ideas. So just to get us started and open up the line, we want to make sure that these are engaging and that you feel comfortable speaking up. Does anyone want to share where their favorite spot to travel in their state is? Oh, I see someone. Was that? Oh, that was Kelsey. We love Charlevoix. If I don't hear from anyone, I might call on a couple of people because I want to know. I live in Michigan, so I want to know about what's going on in Wisconsin or Minnesota. Is there anyone from Wisconsin or Minnesota on the call that want to share? Or Michigan, of course, too. The beautiful North Shore. Thank you, Jamie. New Buffalo, Michigan. Yep, that's a popular spot. What about someone from Wisconsin? We need one place, one spot to visit in Wisconsin. There we go. Wendy says Eagle River, Great State Park. Awesome. Thank you all for sharing. We'll try to do some fun questions like that. Maybe it'll give you some ideas of places to go or things to try at each one of these calls. But as always, we want to make sure that you feel comfortable speaking up, typing in the chat, whatever it is. So thank you for participating and giving us some good ideas. Hand it back over to Kelsey.
Thanks, Elena. And just another reminder, I will add the slides are available as always, and we will put a link to where you can download those in the chat. And then as we get to the end of this session, we will ask for your feedback on these events. We want to make sure that this content is relevant, meaningful, impactful for you. So if you could just take a couple of minutes at the end to give us any and all feedback, we would greatly appreciate that. All right, so let's get into our content for today. So these are the objectives for our session. We're going to review the CDC methodology for COVID-19 prevalence, some of the key components of each of them, and really our goal is to understand and be able to differentiate between these two and pick out which one applies specifically to our healthcare settings. The last thing we'll talk about is how to use this information for potential changes in practice within your nursing homes. So I want to just do a quick poll, which you should see pop up on your screen here. So these are the two different methodologies that CDC is using for COVID-19 prevalence. And I just kind of wanted to get a pulse check if folks know which one of these applies to healthcare settings. Right, so the results are trickling in, and it looks like the overwhelming majority are correct. So I will end this poll. So our community transmission rates is the correct answers. That is what applies to healthcare. And again, we'll talk about the specifics of this, but it's just nice to know kind of where folks are at and how comfortable they are with this content. So I want to just briefly touch on each of the state specifics, since they may vary slightly from what our federal guidance says. So this is the update for Michigan, which does indicate that masks are still required for our healthcare facilities and our long-term care, regardless of vaccination status. So the source link there is down at the bottom, but just wanted to provide that. As we look at Minnesota, their PPE recommendations are tied to community transmission levels. So depending on where you fall in that sort of range, your PPE requirements will vary. The one caveat I have here, and if we have Minnesota folks on the line, I would be curious to hear what your response is to this. But I did hear recently that the Minnesota Department of Health had provided an update on a call that healthcare workers needed to be wearing masks regardless of transmission rates. So I don't know if anyone could validate that. I was not able to find anything on the Minnesota Department of Health website. But again, I would encourage you just to reach out to the state health department, whoever your contact is there, just to determine how they are going to not only interpret, but enforce the CDC guidance, since these two things obviously are not in direct alignment. And it will be important that we're following whatever is going to be the most strict and what your state might say, which is kind of above and beyond what CDC is recommending. And for Wisconsin, they are also recommending universal masking at all times. I was also not able to find anything specific to the Wisconsin Department of Health website, but I did just continuously see the referent link back to CDC. And so we just included that link on the slide as well. So these are really the two approaches that CDC has kind of unveiled in early March for how they are assessing COVID-19 prevalence in the community. And this is kind of how they are saying, COVID's increasing, COVID's sort of at a low level. And I really wanted to spend some time talking about this because there are different sets of rules and guidelines and intended audiences. So it really is going to be important that we know the difference between these two. The community COVID levels that are shown on the left are what's intended to be used by our general public. And this is sort of their decision-making tool for whatever their needs are in their local communities. And the community transmission rates on the right are, again, what our healthcare facilities are expected to follow. From a personal standpoint, I think that the way the CDC deployed these strategies and the very similar naming conventions have caused some confusion. I know we have been receiving a lot of questions about this. Maybe you have a few choice words of confusion as you look at this. And so I just really wanted to spend time talking through the differences between these two. I will say we're going to talk about the COVID-19 community levels on the left, but I don't want to spend too much time here. I don't want this to get confused with what ultimately applies to us as healthcare institutions for our community transmission rates shown on the right. So let's start with the COVID-19 community levels. And again, reminder, this does not apply to healthcare settings, but I think it's just important that we understand what this is, what it looks like, and then have that comparison against what does in fact apply to our healthcare settings. You will see I added this disclaimer at the top of each slide. I don't want people to get confused, so that is there, and we'll just kind of serve as a reminder as we talk through these. So as I mentioned, this is really the approach that communities should use to sort of identify what maybe prevention strategies or behaviors that they need to protect themselves. It includes, you'll see the 3 factors there at the bottom, what our new COVID admissions are, the total number of new COVID cases, as well as the total number of inpatient beds that have a COVID positive patient in them. And so these 3 factors kind of combine into our kind of aggregate community level, which we can then use to make some of those decisions about how we wish to engage with one another, mask, social distancing, that sort of thing. This information might be helpful if you are on a school board, say, or involved in a local community organization or church. But please do not use this professionally. This, again, is intended for the community setting. The reason that they included these 3 factors here specifically is it's a great indicator for not only the impact or the severity of COVID in the community, right? How many people are being admitted to the hospital, but it's also a metric that's reported frequently enough that we can use it to make decisions and kind of keep up to date with what is going on. And the other nice thing here as well is that because it's available, with the same methodology consistently across the country, this gives us a standardized measure to have that comparative look at kind of what's going on. So here's what it kind of looks like in some more detail. So first, we'll take the number of our new COVID cases per 100,000 people. And the determination, is it more than or less than 200? And so once we know our answer to that, which would be, here or here in the gray, we then move into these next 2 items. So the number of COVID admissions and the percent of staffed inpatient beds. So as an example, if we have fewer than 200 new COVID cases, we'd be kind of in this range here. And then we would go on to say, okay, our COVID-19 admissions is maybe, let's say 11, but our percent of staffed inpatient beds is, let's say 9.5. So we then end up in the medium category as well as the low category. And what we want to do in that instance is always favor the one that is higher. So in this case, we would be in the medium category because that will give us the more conservative, more protective COVID-19 measures. So whichever of the 2 is highest is which one you would use. And the CDC website has, and we've included a couple links here, a place where you can check what the status is of your county. All you need to do when you get to this website is, click your state and your county, and it will populate your community transmission level, either low, medium, or high down below, and give you some additional behaviors, again, these preventative strategies that are recommended given that specific level of transmission. So whether you're low, medium, or high, and it'll give you the individual as well as these sort of more broad community level strategies as well. If you scroll a little further down, you will also see a map. You can see how other counties around you are doing. And when you look at this, you see lots and lots of green, which, from a community standpoint, again, is good. We're not seeing high rates of community transmission. We're sort of, pulling back some of our masking, social distancing in the community, which is obviously a trend that we all are eager to see. So I'm not going to spend any more time on this, but just wanted to sort of give you a sense of what this is, the fact that it exists, and just to be aware, not to confuse it with the one that is intended for healthcare settings, in which you may be thinking, okay, so what's the difference between our community levels and our community transmission levels, which applies to healthcare? And again, I don't think these naming conventions did us any favors. And so what I would say to that is there is quite a difference. So if we compare the community-facing metric on the left with the healthcare metric on the right, you can see this is like a totally different picture, right? So our general public-facing image on the left, again, is showing that most of the country is really in low risk, lots of green, with some small pockets of localized medium to high activity where our yellows and reds are popping up. But when we look at our community transmission image on the right, which again, reminder, the one that's intended for healthcare settings, this is really telling us a very different story. So if you take away nothing else from this presentation, remember this, look for the green. If you see the green, that you are in the wrong place, that does not apply to healthcare. So as you're sifting through the information on the CDC website, that really will be your quick visual if you're in the right spot or not. So if you're in the green, you are using the wrong set of transmission levels for healthcare. So let's move into our discussion about the community transmission levels more specifically, which is what we as healthcare administrators and DONs and others need to be using for our facilities. You may also hear this referred to as community transmission levels, but this is the guidance that we'll follow for our healthcare facilities. By way of definition, the CDC really doesn't provide much other than to say very explicitly that this is intended for healthcare facility use only, and that their recommendation is to continue to use this in conjunction with CDC's infection prevention and control recommendations, and allowing that really to guide the way that we are deploying our PPE and other COVID protective strategies. So the community transmission levels just have two factors that they use to calculate, unlike what we saw previously where there were three. This looks at, again, the number of new COVID cases, but it also now includes the percent positivity of our nucleic acid amplification test, or NAT, our viral test, that have occurred in the last week. As I touched on briefly, you can also see on this slide that our color scheme has changed. So instead of that green, yellow, and red, that kind of stoplight image, we now have this nice kind of primary color scheme with our blue and our yellow, orange, and red. So the two factors that are listed kind of on the left of this table, that's what's used to determine the community transmission rate. Again, low, moderate, substantial, or high. And similar to what we saw previously, if you end up in two separate categories, depending on each of these different metrics, you are always going to want to follow the higher of the two. It will be more protective and sort of more conservative approach to preventing the spread and transmission. So if you are maybe in substantial in one and high in the other, you would want to go with high instead of the substantial. So our second polling question is, off the top of your head, do you know what your current level of community transmission is? I know this may be a trick question. If you don't know, that's okay too. But it'll just help give us a sense of kind of where folks are at and potentially what things they might be doing to either alleviate or still have those protective mechanisms in place. Right, folks, just a couple more seconds. I see responses still trickling in. All right, so we're fairly split. We've got 1 in moderate, 5 in substantial, and 7 in high. Which, you know, thinking back to the image we saw of our community spread, right? This is very different. So thanks for sharing your feedback on that. So If you don't know how to find your community transmission rate, I'll just provide a quick reminder. So this is available on the CDC website. If you just go to there, you can plug in, again, your state and your county into the dropdown, and it will display your community transmission level. The one thing I really want to caution against in the event that you have not already run into this is when you do that, when you put in your state and county, what pops up on your screen is not intended for healthcare. So this top table is for our community setting, right? If we go back, you can see it's giving us this green indicator of low. So pay really close attention when you do that. I don't want you to get confused and use the wrong information if you're going through this quickly. So what you'll need to do is just continue to scroll a little further down that page until you get to a map, which will show your community transmission levels. When you do this, your map may still appear in green, as you can see mine did. And so what you'll need to do is just change this drop down from the COVID-19 community levels, which applies to, again, the community, and change it to community transmission, which is what we need to be looking at for healthcare specifically. So toggle that drop down to community transmission. And when you do that, you should now get back to your primary color scheme. And so you'll see these 4 colors. It'll change from the green, yellow, and red. And you should now hopefully start seeing more and more blue pop up here. It will highlight your county and give you kind of this hover over text box that identifies, where you are, what your transmission level is. And I think that this is also a good little tidbit as you're looking around, even your region, right? So is there a county next door or a couple counties over that might be in the blue or in the yellow? And so is there something we can learn from them if they're a step ahead of us? Maybe they've already gone through some of these changes and there's something that they either encountered positively or negatively that we could learn and kind of see how they're doing things. So all of these links that I'm talking about will be included in the resources section. I know Kim put the link to our slides in the chat as well. So you'll have all the links. You can go check all this information out. If you've not already done so, this would be a great website to kind of bookmark and save in your browser so you can keep coming back to this and keep an eye on how your community transmission rate is trending. And this also, when you kind of go through that process, you can see the overall country map as well. And again, just use this to get a sense of, are there folks around us who are in a lower level than we are? Is there something we can learn from them, et cetera? And given the responses that we saw in the polls, while it does seem we have quite a few folks in the substantial and high category, somebody did respond they are in moderate, which is the lowest of the responses that we got. So think about any questions you might want to ask, and we can do that at the end. So what do you do once you have this information? And I think there are a few different things, right? So there are 2 ways that our community transmission rates will impact potentially what we can do in the nursing home or other healthcare settings. They're both listed here. We'll talk about them in further detail, but again, just wanted to include the caveat. If you have questions or are uncertain about what your state level guidance is, I would encourage you to check with your state health departments, and they should be able to provide further clarity if there's anything that differs at the state level from what the CDC guidance includes. So first, we'll talk about screening testing. So each community transmission rate is associated with a different testing requirement, and this will apply differently as well to individuals with different vaccination status. So staff who are up to date on their COVID vaccines are exempt from weekly routine testing. So that means if they have gotten all of their COVID-19 vaccines that they're eligible for, which minimally would be the primary series, and once they're eligible, their first booster, they would be exempt from that routine testing. Obviously, if they are symptomatic or if you are in the middle of an outbreak investigation, these rules do not apply and they should be tested, but just for that kind of routine ongoing screening, they would be exempt. The group who does need weekly testing would be the group who is not up to date with their vaccinations. And so how often that screening testing has to occur would be dependent on what level of community transmission you're in. And this is how the information we just looked up would then kind of trickle through to this. And then we would tell us, which of these categories we fall into and what our associated testing needs to be. So if your community transmission rate is low, there is no screening testing recommended regardless of vaccination status. Once we get into moderate and above, it's at least 1 test a week, but then in our substantial and high, it would be 2 tests a week. So as we move up from blue to red, we're going to have to do more routine screening of both our unvaccinated and or partially vaccinated staff. And it's not really until we get, the high and substantial kind of are in the same bucket, right? So they both have to have twice a week testing, but once we hit moderate and below, that's when we really start to see things shift a bit. And the second way our community transmission rates impacts our facility operations is how, when, and where PPE is worn. So I think we can all acknowledge that it is generally safest to implement universal source control for everybody in healthcare. But realistically, we know that people are getting tired of masks. And while I think that by itself does not make it a good enough reason for us to discontinue masks altogether, we do need to evaluate at what point they're really needed and when maybe they're a little less necessary. We know that in our substantial to high transmission areas that we really need to be masking at all times. And then there's also a few different, criteria or groups of people listed at the bottom who likely should be masking regardless of community transmission levels. If they're not up to date, if they're suspected or confirmed positive, if they've had close contact, or if they have a moderate to severe immunocompromised state. So in the next few slides, we're going to talk a little bit about some of the allowances that could be considered for individuals who are up to date with all of their recommended COVID-19 doses, and when we might start to kind of relax that universal masking as an example. So here are some more details about the PPE that's required for resident care in our substantial and or high transmission counties. And based on what the last poll said, this is the bulk of folks on the call. So N95s should be worn for all of our aerosol generating procedures. If their resident has COVID, or if there's other events that are occurring where a high transmission potential exists. So, if the room or the area is poorly ventilated, if the resident can't use source control, or if the resident is not up to date with their COVID vaccine doses. The other piece of this is eye protection. So our goggles or face shield that covers both the front and the sides of our face, which should be worn during all patient care encounters. You may opt to say, I think that we'll just move to universal use of N95s or higher for all patient care encounters, just to sort of have that blanket. We're not going to say when an N95 should be used or when we can use a surgical mask, and just have that standard. We're using N95 for all patient care because our county is in substantial or high community transmission. That may make it easier for you to communicate to staff. It may also make it easier for staff to know, okay, if I'm doing a patient care encounter, I have to wear an N95, versus trying to tease out in their minds when an N95 is necessary, when a surgical mask is necessary, which may have the potential to lead to some confusion there. So that's up to you and how you want to go about doing that. But again, at a minimum, should be an N95 for the encounters that have a high risk of transmissibility potential. In areas that are moderate to substantial community transmission, CDC recommends the use of PPE, face mask, and eye protection for healthcare professionals who are caring for residents, even if they do not think that they have COVID. So just a little reminder on that. And then as we look at our low to moderate community transmission, and I know we didn't have anybody who responded saying they were in that low category, but this is what it would look like if and when we get to that point. So for our healthcare workers who are up to date, they can choose not to wear source control if they're in a non-resident facing area. So maybe a break room, if they're in HR or a conference room with other staff. They should still be wearing source control when they are in areas of the facility where they might encounter residents. So if they're in a hallway or a dining room, maybe the activity room, that is an area where masks should certainly still be worn. As always, there's nothing precluding them from continuing to wear these if they just feel more comfortable. That's always an option. But that is when it should be worn when there's a potential for a resident encounter of any type. Certainly, source controls should be worn when in areas for patient encounter, as I stated. And related to residents, so for residents who are up to date with their vaccines, they may opt against using source control in facility common areas. I think sort of the caveat here, or one thing to consider, is for our residents who are at increased risk for severe disease, maybe severely immunocompromised. Those folks, we should consider either practice of physical distancing or the use of source control if that is something that we continue to worry about. The other thing I will mention here too is this related to residents. It does apply for their visitors as well. So residents can choose not to wear a mask when a visitor comes to see them, even if that visitor is not up to date. And this was something that was kind of spelled out in further detail in the QSO 2039 memo, basically stating, that they can have close contact, including touch with their visitor, regardless of vaccination status, and can choose not to wear their face covering when other residents are not present. So here's a list of all the resources we went through today. I would encourage you, if you have questions, please drop them in the chat. I know Elena will facilitate a Q&A for us, but these are some sites that you can go to for additional information. Maybe again, just bookmark them, save them. If it's not something you look at regularly, you could certainly think about that and how you want to integrate this information into your practice as we start to hopefully begin to have our community transmission go down and be able to relax some of these guidelines accordingly. So with that, I will pause and stop talking. Elena, I will turn it over to you for Q&A, and would again just encourage the folks that are on the line, if you have any questions, feel free to unmute yourselves, drop them in chat. This is your time to talk and get feedback from one another.
Thanks, Kelsey. I'm not seeing anything in the chat right this second, but keep them coming if you're already typing it out. One thing I just wanted to know, as Kelsey went through that presentation, I thought of this. How are all of you keeping track of your community transmission rates? Have you found any resources that maybe email you when your community transmission rate has changed or anything like that that you could share with others? I just think that there are so many things that you're working on tracking and keeping track of, and you're dealing with patient care and everything that you're helping with right now. It's so difficult to look at everything you need to look at on a weekly basis, or however often you like to do that. So are there ways that you're getting notified when things change and when you can relax or put back into place some of those things that Kelsey mentioned? All right, I'm not hearing any. Does everyone just kind of use that website that Kelsey shared to look that information up? And if so, how often are you doing it? Weekly checks every other week? We download weekly on Mondays and track the transmission rates with how many times a week we are testing. Great, thank you. Thanks for all of that information. Sounds like it's a little bit, it varies a little bit. Their headquarters sends out a notification on the same day each week. That's really helpful. Maybe we can look into it a little bit more. I know I was getting some sort of an email, but I think it was more not what health, the one that healthcare, the community transmission rate. I think it was the opposite one that I was getting in my email, but maybe there's something out there that would be helpful that sends a weekly update. I can kind of look into that and give that information over to Kim and Kelsey and Jerry to see if that's something we can share with you all. But it's so difficult to keep track of that, to keep track of who's getting vaccinated within your facility, who's getting the booster and all of that. So really commend you all for keeping track of everything that has been put on your plate and your staff's plate over the past couple of years now, because it's really difficult to keep track of all of this, and do your best at making sure that when things change, that you're communicating that out with all of your staff as well. Leading Age sends out a biweekly update with county transmission rates. Thank you, Ashley. That's really, really helpful. Awesome. If anyone else thinks of where you might be getting some of those updates, if you think of something like, oh, I do get an email like that, feel free to pop it in the chat to share with others, because I think we all probably learned some tips and tricks over the past couple of years too that would be helpful to share with others. Clara says that she tracks through email, screenshot of the map and timestamp that I send to my DON every week on the same thread. That's really smart. That helps you kind of see week to week where you go. Awesome. Thank you all for sharing all of that information. What about, Kelsey shared those two different areas, screening, testing, or source control. So as the community transmission rates change, what do you find the most difficult piece of that is? Which one, the changes that occur, which one of those two areas, the screening, testing, or the source control, do you find most difficult to either scale back or put into place again based on your community transmission rate? Source control, so wearing masks, masking, all of that, that's pretty difficult. And I know Kelsey gave that tip where potentially if you're in tracking all of the staff testing. Yeah, so I think it's kind of all of it, isn't it? It's really, you want to allow some flexibility in what you're doing based on the community transmission rates, but it also makes it so that you really have to communicate things out, change your internal processes constantly, really, if you want to relax things, but then also go back to kind of putting those things back in place when those transmission rates go up. That's really helpful. And I know Kelsey mentioned that suggestion, and Kelsey, let me make sure I say it correctly, for what to do, like if you're in substantial or high, was that what you said? To just have that be? Thank you.
Yes, yep. So, and again, it just totally depends on your facility and how you want to handle this. You may consider just a standard across the board implementation of N95s during all patient care encounters. This only stipulates that that has to be true for certain instances. But again, how do you tease that apart, communicate that effectively? Is that going to confuse staff? Are they not going to know what they need to do? So just for sake of simplicity and standard messaging, you may opt to go that route.
Thanks, Kelsey. Yeah. What other tips and tricks have you put into place? So We've heard some things on how you keep track of your community transmission rates. I see, Clara, you said the change in PPE is really difficult. No eye protection one week, then needing eye protection in the next, and hard for staff to readjust. I feel that on so many levels. It's so difficult to keep your mindset on the right place when it's changing all the time. So what types of things, like how do you communicate those changes with staff? And then what types of tips and tricks have you implemented to make it easier on both your leadership, but then also on your staff so that they kind of know what to expect as well? Has anyone had some good things or on tracking all of the staff testing, anything on either of those two, source control or that testing aspect? Are there any really cool things that you've implemented to kind of make it easier?
This is Stacy from Vernon Manor in Viroqua. I've been every week on Monday sending out what we call a testing update, just saying, do you need eye protection or don't you? What are the testing requirements for people who have an exemption? What are the testing requirements for somebody who's not up to date? And then what are the testing requirements for staff who are up to date? Just because there's been so much confusion for the staff.
Yeah. Thank you so much, Stacy. And I'm glad that you mentioned all of that. That's probably helpful for so many people on this call. And it sounds like, I'm guessing that since you're mentioning it, it's been pretty successful as well in making sure that staff expect that email too, so that they know to look at it to kind of get a feeling for what their work day ahead is going to look like.
Yeah, and we've been posting that at the doors so they know when they come in.
Perfect. That's a really great idea too, because I know sometimes I'm not checking my email first thing in the morning, but I definitely am opening that door and seeing that notification right there. Thank you again, Stacy. What about anyone else? Is anyone else implementing something similar to that or anything slightly different than that you want to share? Right, not hearing anything, and that's okay, but hopefully Stacy's idea can kind of help some of you with some of those things. I know a big thing is just communicating it. There are so many changes, so how do we make sure that everyone is aware of what it's going to look like in our building this week? The next question I just have, I guess, with testing, have you found it easy for those who aren't up to date? Are they accepting of those tests or any challenges with that piece of it? Or is it just they know that this is what the expectation is because they haven't gotten up to date with their vaccination, that this is just the reality of what it is? Or are there some difficulty with that as well?
I guess I would share that I think it is difficult to keep track of those that are not up to date and ensuring that they do get tested twice a week. Because there's some that don't just take that on their part and I'm having to track them down and we need to test. And so if they would initiate that a little bit more, it would be helpful knowing that they need to be testing, but keeping track is definitely hard.
Yes, I understand you on that for sure. It's one of you and many of them potentially. So it's really difficult to keep track of that rather than having it kind of be on each of the people that need to test. And that's not something that you can necessarily force on someone. I'm sure you have some people that are pretty good about it because they know that that's the reality, but it might not be across the board. Wendy also mentions we've been having a very trying time trying to keep people tested. It is constant education. Absolutely. Has anyone found some good strategies around tracking people that need to be tested or kind of putting the onus on the staff member rather than on one person who has to track down several staff members, anything like that?
You know, before I left the nursing home I was working at, we had also had an issue with staff not testing and being accountable for testing. And, you know, again, yeah, we don't have the nursing staff to keep track of all this. And we actually split it. At one time, we literally had our maintenance department keeping track of the data. And then we switched it over to health information, who took it upon, we you know, trained and educated them on how to use the data that, you know, that we were getting it from. So then, not that the health information department, of course, had to go out and tell these people, but then it was an easy list to give to the charge nurse or whoever that supervisor was on that shift to say, here's the 3 people that need to get tested this week. So it was more doable that way, using non-clinical people to establish that list.
Great idea, Kim. Yeah, thank you. This is kind of a side note too, when we talk about tracking all of the vaccinations, the boosters, now the second booster potentially for those who are eligible. Have any of you started to use that new event level tracking form? Kind of another one that is an interesting naming convention for that as well. But has anyone started using that for tracking? Can find it really quickly and pop it in the chat. Vicky says I've been using it and it is great. Yeah, I
Yes.
haven't gotten to dive into it quite as much as I would like to, but on what I have heard about it in some webinars and things like that is much easier to use. So I'm going to post that in the chat just so, and maybe it's something we can focus on one of our future calls too, since it doesn't seem like maybe there's not a ton of you that are using it quite yet. Maureen, sounds like you're using it as well, potentially, but you need to review the training material. So yeah, this page is pretty good. If you go to this page and then up at the top, there's the section that says on this page, and there's one of the links says event level COVID-19 vaccination forms. If you click on that, it'll jump you right down to the section where there's a reference guide. It has the worksheet and a couple other things within it as well that could be helpful. But that might be a really great new tool to start using for tracking purposes. Again, it's something we might be able to deep dive in a future call, but highly suggest using it. It does, from what I've heard about it, it does sound like it's more straightforward and easy to upload, correct, Kim, directly into NHSN?
Yeah, I helped a nursing home. They were having questions about it. And once the data was entered, oh my gosh, it is one-stop shopping, so that when you update a person's status with a vaccination, or if they discharge, or if they come back, and that's with employees too, it is just so easy to now, you know, to manipulate and to get the data without having to remember when someone becomes eligible and so on and so forth. It does it for you.
Vicki, any thoughts on what the biggest difference, like how has it made it easier for you to use, excuse me, because you said it's great. So what's the biggest difference? Like what could you tell someone else on this call that has made it so much better for you?
Well, after the initial setup, I mean, you just go in and update your data and you're done. I mean, you know, you just have to verify the numbers, and that just takes a very small portion of the time. I used to spend an hour or two on my entry date trying to get the data, you know, correct, just with my addition, and it saves me a lot of time. The one thing that I do find is a little different, like if when I make a change, say I make the change on April 25th when I did my data entry, it took me all the way back to March 28th. So I had to go in and refresh and look at each one of those data entries because I don't know why it goes back that far. So
There was like a little glitch or something.
I don't know if it's a glitch.
Oh.
It's happened every time I've done it. So I'm thinking it's absolutely part of their system, but so you have to update for weeks back when it only affected the 1 week, you know? So
Okay.
so it took a little bit of time, but certainly not as much time as it took me to do the math.
Well, thanks for letting us know that too. We'll take a peek into that as well and see what the reasoning behind that might be too, and see what's going on.
You know, because like for instance, I added a new staff member, you know, on 4/27 or something. So it would have been on the week of 4/25, and it took me all the way back to 3/28. Well, it didn't affect those dates at all. So I don't know why it made me go back and review each one of those, you know.
Yeah, that doesn't sound right. I'm not sure why. Yeah, that doesn't.
Because I would think it should just do the 1 week that you made the change in, you know.
Yeah, this was what was supposed to be easier for it. If you put in an update on a change, then it would change anything else needed, whether it was before or after.
Okay, well, it didn't. I had to do each
Gotcha.
one of those manually.
And Maureen's saying
It's
that
not so-
she had the
it's
same
not-
issue.
Well, it's not so bad early in the when there's only a couple of weeks to go back, but if you get a year in and you have to make a change and you have to go back, that would be, you know, pretty cumbersome.
Okay, and I see we have another, yeah, okay.
Yeah, this is really helpful. Maybe we can bring this up to the NHSN help desk even.
Exactly.
And let them know that people are experiencing it and they love the tool, but that's kind of strange. So we can kind of let them know that so that maybe they can have a fix for that piece. They might
Initially, I
just not
thought,
know.
oh, this is too much work, but once it was entered in, it's wonderful.
Thanks, Vicki. Yeah.
It's definitely worth the time.
In the
Awesome.
slide deck, it talks about it going back to March 28th because that's when it went live.
Okay.
So that's why I think it's doing that, but it seems kind of redundant. The information's already in there.
Right.
You know,
Yeah,
we
well,
put that in manually.
exactly. We'll look into that a little bit more. And like I said, we can kind of reach out to NHSN and maybe even put in something to some of our contacts at CMS, letting them know that something like that is going on, that if it's something that isn't necessary, why do you have to click through all of that again? So we'll kind of give them a heads up that we're hearing that from you. And we really, really appreciate having that conversation. That's helpful for us to know that that's something that you're experiencing, because we can kind of push it along too and keep track of it.
And just out of curiosity, was it asking for anything in particular, or just that you review and validate that prior information all the way back to March 28th was still accurate?
What it does is it says something about data changed or whatever, and then you have to review that to make it. I forget exactly what the words are. It shows the weeks, and then it shows in parentheses data change since submission or something, and then you have to click on that to update it.
Vicki, if you see that again this next time that you submit and you think of it to take a screenshot or something like that, and you want to send it along to someone on our team, that will even be helpful too. So we can kind of, like I said, alert the NHSN help desk. Again, if you think of it, I know there are a million other things that you're thinking of, but if you happen to think of it, you can feel free to send that along to us.
Well, so far this week I haven't had to make any changes, but
Yeah.
well, if I do before Friday, absolutely.
Sounds good. Thanks so much, Vicki. And thanks, Maureen, for adding to the conversation as well. Is anyone else using that new tracking sheet that hasn't gotten a chance to speak up? You can pop a yes in the chat, or if you want to learn more about it, let us know in the chat. That way we can focus some of our energy on creating something for that. All right. I guess it'll be a little bit of a mystery then. I'm going to assume that maybe there are some people out there that aren't using it, but now are a little bit interested in it. If that's you, like I said, you can still put it in the chat, but that's me.
It's
Oh,
me.
perfect. Ashley, thank you. Now it's not so much of a mystery. So there might be some others out there that I think are probably in the same place as you. So we'll look into that some more. I know we've had some team members that have listened to some great webinars on it. And there's lots of resources that we can kind of narrow down and hopefully put together a presentation for you on that so that you can all start to benefit from using that, but have a little bit more information on it. With that, I can kind of turn it back over to Kelsey. I know that Kelsey put the evaluation into the chat here, so feel free to click on that and give us some feedback. We appreciate it. It helps us for our future events. But we have about 5 minutes left. So are there any other questions for us before we finish up for the day? All right, I'm not seeing any. So with that, I'll hand it back over to Kelsey. And thank you all so much. This was a really, really great call. It was so nice to hear from so many of you. And we encourage you to bring forward those kind of things, those pain points. Like Vicki, what you mentioned is a pain point. It's just kind of annoying. Why do we have to do that? Those are the type of things we want to hear from you on. So please feel free, even if it's not topic specific to what we're talking about that day, you're always welcome to bring things like that up at this call, and we can kind of help navigate it, push it forward, get some answers, and help out and address it at a future meeting if we can't do it during the meeting. So thank you all so much. I really appreciate it.
And Elena, you made a great summary. I have nothing further to add. So thank you all for joining. It really was a great conversation today, and we appreciate your willingness to engage. And we will see you all back next week for our next session. So thank you so much. And if you haven't had a chance yet to download the slides or do the event survey, we would appreciate it.